Welcome everyone to the third webinar that we have created in this partnership between WHO Zero, the Koita Centre for Digital Health. And I think I'm not going to explain again, because all of you are here already, how important responsible AI is going to be in healthcare and how much health will be transformed by AI. Now, one of the key things that is going to be critical in this entire area is data. By the nature of health, all health data is private, health data is sensitive, and by the nature of AI, you cannot build high quality AI that works well without gathering and using a lot of data. So if we go too far in the direction of protecting the data, we run the risk of data inequity and people whom the AI is meant to serve not getting served. On the other hand, if we become too careless about how we collect and use data, we open ourselves to huge potential for misuse, and people who were supposed to benefit from health AI might actually suffer because of what we did. Now, this leads to a very typical problem of lean yet balanced governance. Structures that are designed to meet the need, but no more. And how do we decide that? What are the principles on which better data ecosystems can be created? And that's the type of discussion we'll be having throughout the seminar today. We have with us leaders of the field, and the first person to take us through a keynote on this topic will be Professor Ilona Kekbush. I've had the pleasure of knowing Ilona for multiple years now. She chaired the Lancet Financial Times Commission on Governing Health Futures and is directing multiple initiatives at a global scale, and is currently at the University of Geneva and directs Digital Transformation for Health Initiative. Ilona has been critical in coming up with ideas like data solidarity, a wonderful topic that I'm sure we'll hear at some point during the keynote. We will follow this with a panel discussion with Professor Gautam Menon from Ashoka, Professor Sangamitra Bandyopadhyay from the Indian Statistical Institute. Professor Menon and Dr. Sangamitra bring very quantitative skills to areas like health. And we will discuss about how we can do this better, protecting at safeguards from institutional sides or from computational sides. And finally, we also have Dr. Bunchai, a health and health data expert from Thailand Health and Standards Development Center, who will take us through this. Finally, to end this, we'll have a country spotlight, this time on Sri Lanka, by Mr. Jayanta Fernando, who has been absolutely critical in taking forward these areas for Sri Lanka at a governance level. And I'm very glad, Jayanta, you have joined us. And we will get to see how countries are dealing with this problem at their level. I will not take too much more of your time. I know that time is always short with such eminent speakers amongst us. So with this, I will hand over to Ilona and the team, depending on the preference. We can project slides from our side for Professor Kekbush. Over to you, Ilona.
Thank you very much, Anurag. And in your usual humble way, you did not say that you were the co-chair of the Lancet Commission. So there was two of us, and it was wonderful working with you. And I'm so happy that we are still cooperating in the new initiative, the Digital Transformation for Health Lab and Consortium. So I hope if we can put on my slides, that would be very helpful to lead you through yes, thank you. And maybe if you can enlarge them for the audience, that would be great. Any hope?
Yeah, can we go to slideshow mode, please?
Yes.
Thank you. Perfect.
Good. All right, so I'll try and lead you through this reasonably quickly because a lot of it can also be looked at in more detail in the things we have published and on our website, of course. But to the issues that Anurag has just put on the table, we have developed an additional term and concept and approach that we call data solidarity. Actually, in many countries, the healthcare system is built on solidarity in different ways, through insurance models, through tax-based healthcare, etc. And we feel that in the age of digitalization and artificial intelligence, a solidarity model needs to be developed for health data for many obvious and some slightly less obvious reasons. So we think about data solidarity for equitable and trustworthy data ecosystems, which is what I'm going to speak about. The next slide just draws your attention to the Lancet and Financial Times Commission, where we try to work on some of these issues and give recommendations. And I just want to highlight here, because this is so important for data solidarity, that the Commission made a very powerful call for governance of data and digital technologies, and that such governance needs to be built on values. And of course, the focus of the Lancet and Financial Times Commission was health data. And I just want to highlight those values because they appear frequently in our thinking and as I continue, and that is democracy, equity, solidarity, inclusion, and human rights. And you will find some of these values, of course, also reflected in the Sustainable Development Goals and in some of the AI and digital initiatives that have recently been created in the context of the United Nations. I personally feel the United Nations has waited far too long to take on the issue of governing digital and AI, but finally we are seeing some movement, and I believe that's really helpful and interesting. We got the approval that after the Lancet Commission, we can try and take the recommendations from the Commission forward, as you'll see on the next slide. And this is when we created the consortium that you can see here. And of course, you see Ashoka University here. We have consortium members in Nigeria, and we work with a whole range of other partners around the world. And particularly, and I want to underline that, you see that as the slide describes the consortium, that in working on value-based digital transformations for health, we are working with young people from all over the world. We've appointed young people's health ambassadors. They have councils. They help us in our research work. They give recommendations, because we feel very strongly, particularly if we look at some of the countries that we're working with. I think of India, I think of Nigeria, I think of others, where a majority of the population is actually young people, that this is absolutely essential, that they have to be part of how we envisage the future. You can see that we're working on various issues, all of which, of course, have a governance component. And but here we will focus on what we are doing in relation to digital and data governance. So our vision obviously is, as the next slide shows, that we feel very strongly about using the terminology digital transformations for health. We very frequently see that many of the approaches to governance speak as if they were just regulating a technology. governance of the digital world and the digital ecosystem is so much more. We are regulating basically also a power system, and we're obviously regulating the distribution and the access to data and information and so much more, which is why it is absolutely essential to be led by values in order to have equitable outcomes. So we've worked further on those foundational values. I'm not going to spend much time on it. You can see a visual representation on the next slide. And what we are presently actually negotiating with the Lancet is to embark on a follow-through Lancet Commission, because literally so much has happened in the very short period since the publication of our report that we would like to take a whole range of these issues around responsible governance forward. So the way we have approached the issue of stronger health data ecosystems is, I give some points on the next slide, that we have to see that the ecosystems themselves, the digital ecosystems, are an important determinant of health. And we're presently working on a Lancet series to try and outline in more detail how this acts as a determinant of health in terms of how it shapes access, who gets to decide on the access, how vulnerable groups are enfranchised, the extent to which powerful players are regulated or not regulated, and of course, particularly in relation to health data, the issue of oversight and governance and solidarity. So we've developed a couple of points how to enable better data ecosystems. The first is obviously to link it also for the health discussion, as the next slide shows, with the debate and the development of universal health coverage. We think we need mission-oriented innovation, and we need a public health mission in relation to data governance in health. We feel that there needs to be strong governance to curb excessive data extraction of certain groups, but also of whole parts of the world and continents, where the data are then stored and accessed by large tech companies, mainly situated in the United States, and regulators from other parts of the world do have no influence on that. Some of you might be aware of the very difficult situation right now, since I'm speaking from Europe, is the tensions between Europe and the United States in relation to the AI and digital regulations that Europe has put in place, and particularly the issue of the European health data space that has just been adopted, and the pressure that is exerted when the companies that are active in Europe actually don't adhere to these rules. We've been thinking about a taxation system that is wider than just individual countries. So we need fair rules for a digital economy. And we feel very, very strongly that we need to develop a shared taxonomy to create global standards for health data. And we see a very, very key role of the World Health Organization in this context. And we hope that despite the major reorganizations happening now at the World Health Organization, this will be taken forward. So as you're very well aware, we will need action at the global level. We need action at, in some cases, at the regional level, as we see in the European Union, but obviously also at national level. And we see the difficulty, particularly also in Europe, to find the right balance between data sovereignty, that's very important for many countries, and data solidarity, which implies a certain amount of data sharing. And I think this is an issue that will come to the fore even more. So if we go to the next slide, we are very keen to increase country ownership of digital health strategies. We find that too many countries still do not have digital health strategies. There are, of course, very difficult issues to resolve. We just see this in Germany, that for the first time has created a Ministry of Digital Affairs just 2 or 3 months ago. And we also see it in the European Union, that the cooperation then between such digital ministries that have quite different approaches, many of them related to global competition and investments and innovation, and the health ministries that have a more user-oriented and value-based approach to this. This is something we're trying to address through issues around open source models, participatory design, and collaborative public health infrastructures. And of course, particularly in health and health research, the question of data reuse is a very, very central one. So if we move on to the next slide, please. We, as I said, see solidarity as a bridge, the concept of data solidarity as a bridge between the notions of privacy, ownership, personal ownership of data, data extraction that actually does not respect this, and the creation of a possible collective benefit. And so we're putting our mind to building a public trust architecture. And in order to do that, we further developed the issue of data solidarity. You can see the way we have created the typology around that on the next slide. And the kind of issues that we are raising. You can look at this in more detail in a white paper that we've developed that's on our website. And in order to get clarity with many of the terms that we use, we've also developed a glossary on data solidarity. I think the most important thing in the concept of data solidarity is to focus on data use over data type. And this is actually how we are moving forward. We are thinking about systems that enable good data use for public values. We want to establish elements that prevent and mitigate harms and also give consumers rights if they have been harmed through harmful data use. We actually think that high-risk, low-benefit data use should be prohibited and penalized. And we're thinking around data commons, collective ownership in terms of community benefit. And it's very interesting that particularly at the local level, at the city level, some of these ways of taking it forward have been implemented. It's also very interesting to see how Taiwan is applying a whole range of these principles as well. So if we can go to the next slide, we feel also, and this is related to the local dimension, that if one talks about Okay, so I thought we were at another point, but here you can see what we have developed in order to support a solidarity-based approach. We have the glossary, we have the white paper. I've mentioned that, and we are launching here, actually on Friday, an implementation guide for data solidarity and maximizing public value from data for institutions and organizations. So by early next week, you would also have the implementation guide on the website. And you can see here that we are trying very hard to rebalance the debate around such a model of data solidarity. I'm coming to the end. We feel very strongly about public participation in this whole approach, as the next slide says, and I've already mentioned earlier that we are working very closely with young people in shaping and designing these issues, and co-creating through inclusive governance. And this is where we have, for example, worked with the Council of Europe to think further about what citizenship means in a digital world and what citizenship for health means in a digital world. So to end, if we want to move towards sustainable and inclusive data governance, this is my last slide, then it is absolutely critical to ensure equitable access. We think data solidarity is a key to be able to do that, to build equitable and trustworthy data ecosystems. We want to make sure that the specific health considerations and health data are such an enormous part of the data that are out there, that are being collected, that actually generate significant profit on the one hand and innovation on the other hand, that we need to have a concept for countries to maximize public value. And we need to build an ecosystem that builds trust, protects data, and rebalances power. To give you an example, we've just had a popular vote in Switzerland last weekend on introducing electronic ID. The votes came out 50.1% for an electronic ID. And actually, the situation now is because of the lack of trust. This was the second time round the Swiss population voted on this. The first time round, the ID was to be coordinated by the private sector. That was not adopted. Now it was to be done by the government. But one can see that a 50-50 result doesn't really reflect total trust in the Swiss government. So now, even though there's been this very, very slight higher acceptance of the electronic ID, the government and particularly the parliament is discussing that probably on such a very small margin, one cannot move forward with electronic IDs. Now, as Indians, you might scratch your heads and say, you know, what are these crazy Europeans up to? But it does reflect that unless you are able around the digital transformation and the AI transformation, at least here in Europe, unless you're able to build trust in your government and in the governance that is taken forward, there is actually no chance also then to implement many of the fantastic innovations that come with digital and with artificial intelligence. And therefore, the issue of governance is so important, because otherwise people really miss out also on the potentials that we have basically at our fingertips, but need to be accepted by the population overall. Thank you very much.
Thank you very much, Ilona, for highlighting the importance of trust and the importance of use over the type of data. Sometimes we get too mechanical in which data is important. What is important is what use. For example, I can think for myself, even if something as private as genomic data was being used for a very important social purpose, people are usually fine. But use of genomic data to create products that will create no return, no benefit, no public health value should actually be banned, exactly as you said. So thank you again. I know that you're in another meeting, so please feel free to stay as long as you would like. But now we'll move on to our panel discussion. And I invite the panelists to turn on their videos, Professor Menon, Professor Sanghamitra, Professor Bunchai. I think you're all here. Yes, thank you. As we saw from the keynote, health is complex, data is complex, and in general for AI, the usual thing is let's collect a lot of data. Because the system is complex, collecting a lot of data must be the answer. Now, there are clear risks in that data wrongly collected, wrongly guarded, wrongly used. And that's why our panel discussion is on collection to care. Can't just collect it, you have to care about it, how you're going to use it. And first, Gautam, I'll come to you. Because as we go through this business of trying to solve complex systems by collecting lots of data, we run the risk of making things worse in a variety of ways. And at an institutional level, some things can be done. So perhaps with you, let's start with what can we do as institutional safeguards to make sure that the use remains central, not getting caught in the details. Over to you.
Yeah, that's a wonderful question. I mean, ideally, what you would like to do when you collect any form of personal data is to work with perfectly anonymized data. But if there's one thing that we understand now, is that there is no such thing as perfectly anonymized data. Every additional bit of information makes it exponentially easier to identify the person from whom that data actually came. And typically, this involves cross-referencing multiple databases. And this is not helped by the fact that much personal information is already available to the public or on the dark web. That's why the difference between high-income countries and LMICs is particularly clear. You have large data availability, for example, in a country like Finland, where you have a whole bunch of genetic information on the population, versus India, where it's sparse and typically restricted only to a higher income segment. This has skewed medical practice, as you know. So it's important. It's right now extremely important to be able to try and understand what standards should apply in terms of practice that can only be obtained by medical data on Indian populations and on Asian populations in general, populations without that large level of coverage. So I just want to go back to the point that you've made that data availability for public health purposes is actually very crucial. But there's a balance to be struck there. You should not go too far to protect data, but actually to be of use, and sovereignty and solidarity, as Ilona mentioned, are two major principles that we can base our ideas about data on. So I think what's needed is a shift in the nature of governance by which you penalize misuse very strictly, but not limit use, and create an ecosystem where you assume some level of trust right from the beginning. This is particularly difficult for India because India is largely a low trust society. So the tendency is to put in as many restrictions as possible. And that makes it much harder to proceed, especially in areas such as this. So what you need are strong legal processes that function, impose penalties on a fast time scale. And that's where Ilona's point about issues of governance being important are very crucial here. And here again, you could take the point of view that, look, this is philosophically fine, but how will you implement it? And that's where the difference in implementation between HICs and LMICs become important. You spoke about bias. You'd asked about bias, and that's certainly an extremely important question because what data is itself collected is itself a sort of moral and ethical choice. For example, you might want to have discussions that surround community or caste in India. These are important questions when it comes to deciding how to target particular interventions to particular sections of society. However, information like this is sensitive private information, and how exactly one is to factor this into medical decisions or public health decisions while preserving the privacy and anonymity of communities is a hard question. And again, that's where penalizing very strongly the misuse of such data might be a better way of doing it. And also, not just health, since you collect information about that is fairly broad in terms of people, there's also financial information there, which is not just health information, but other types of information that typically are included along with this. So that's another larger question about the collection of data and eligibility, for example, for certain government schemes, which indirectly will tell you about financial status of the individual who's collecting it. So the suggestion at the institutional level would be to create hierarchical methods of access so that no person, except at a very senior level, has access to everything, but we can carefully silo parts of the data that people can see, ring fence only to authorized users. And since the last point that you wanted me to deal with is complex systems have this ability to be both fragile in very particular points and also large scale robustness is also a feature of complex systems. So the question is to constantly interrogate the points of fragility and make sure that they are not points where you can break the system completely. And that's special to these sort of very large distributed structures that you want to create when you think about it. Synthetic populations as an alternative to personal data that basically reproduces personal data on a statistical level might just be an alternative that I think is increasingly an interesting alternative where you don't really have to extract individual data, but you combine it in such a way that you cannot go back to the individual. That's just some points that I have. Stop there.
Thank you very much, Gautam. Sanghamitra, I'll come to you next. No matter what we do at an institutional level, enforcing those regulations can be a challenge. So as a computer scientist, how do you think we can solve these problems on the computational side, given that data will contain bias, given that data may not be properly collected, may not reflect? How do you deal with this? And I mean, you do work on this, so I know that you deal with this every day. Over to you.
Yes, I'm audible, I'm clear,
Yes.
right?
Yes,
Oh,
absolutely.
fine. Thank you very much, Anurag, for that question. Yes, data, we are collecting data at a humongous rate now. A lot of it is available, and there are a lot of problems in the data as well. And that the computer scientists, the mathematicians, statisticians, they have to get together to solve this problem. Number one is data quality. There are measures of data quality which have to be, applied religiously before you actually start analyzing, doing analytics with that data, because garbage in, garbage out. So if the data is not proper, whatever you get out of that data will be nonsense. So, and of course, the bias, there are different ways in which bias gets into the data. One, of course, is the data-driven bias, which is there. The algorithmic bias is also there, as well as human bias. I mean, and of these three, the human bias is something which is very, very difficult to detect and to correct, because it is in the mind of the individual who's actually programming and stuff like that. So, for example, if I think of, first of all, to talk about equity of AI in healthcare so that it's fair, it reaches the people who need it. And also from the computer scientist point of view, poorer countries, how do they get the benefit of this AI in healthcare? One is, of course, the resources. Resources are nowadays extremely expensive, available to a select few. So it is here that the government, because individual organizations, even organizations, universities, etc., even in India, it would be very difficult to get those resources which are necessary to do a really meaningful stuff with AI in healthcare or wherever. Now, that is where I think the government has a major role to play to make the resources accessible, right? So the computational resources, the data, all these, to make it accessible to the masses, there can be, and that is where India is already thinking about it, that they have the centralized resources where you can grant access to the different institutions. So that is one way in which the inequity can be addressed, because not all organizations can afford to have those high-performing computing systems. So that is one aspect of it. about the computational part. And the other thing is about the data itself. For example, one very common bias is imbalance in the data, right? I mean, there are some classes which are very small in number, and there are huge other classes. There are many data points from that other class. And if the algorithm just predicts that every point is in that larger class, then also the overall accuracy is very high, right? So that is there, in order to address those issues, we need to come up with metrics which can actually detect that, okay, maybe the overall accuracy is very high, but the class-wise accuracies are, one class may not be able to detect or recognize at all. So there are measures which can detect this, and those have to be applied across the board. So these type of things, even in the data, for example, the gender, ethnicity, marginalized communities, hardly any data is there in the training data set. So with such biased data, if the algorithm is trained, and nowadays it's all data-driven science which is happening with the large language models as well as the small language models for that matter coming in, it has to be, not only institutional safeguard, algorithmic safeguards. There has to be standards, international standards which are to be developed. It's already also happening, where you have certain checkboxes for the data, and you have to make sure that the data which is given out for training, etc., it clicks all those checkboxes. So certain standards have to be enforced. For example, gender is one thing which now it is explicitly taken care of, but at one point of time, gender was not taken care of. For example, most of the training data were from men, cardiovascular diseases. It was trained all for males, and therefore females were treated only as a smaller version of the male, and it was misdiagnosed in a lot of times. It was misdiagnosed. Women health suffered. These days, of course, gender is one of the important criteria which has to be checked. But then there's a third gender. There are other types of people who do not get, data does not get collected from those populations. So that is something which has to be taken care of in the algorithm itself. And with huge amount of data, a lot of privacy issues, trust issues, they come in. Synthetic data. If we can generate synthetic data which mimics the real data very closely, then that is one solution which can be, used for proper training of these algorithms. And of course, nowadays, as you will note, that large language models are being used everywhere. Okay, transformer-based large language models. Now, large language models are guaranteed to hallucinate. So there are approaches which are algorithmic approaches which have been innovations which have been brought in. For example, the RAG, which is retrieval augmented generative AI. So those have taken care of hallucination to a large extent, yet these systems are known to hallucinate. The large language models, for example, any of these chatbots that we have, ChatGPT or anything, you prompt it, it gives an answer. You say that, no, I'm not happy with that answer. It'll give another answer. If you keep on saying that, no, I'm unhappy with that answer, at the end, it will give garbage, absolutely meaningless responses. So it does not know how to say that, no further, I cannot say anything further. So these are the places where the algorithms have to be stronger, and people are working in this. The last thing that I want to say is that in order to address the problems of equity in AI-driven healthcare, one approach is, of course, the open code. Data sharing is one aspect, algorithm sharing, code sharing. Okay, even if you cannot share data, if the algorithm is shared, then the people can, they are able to use these algorithms.
I think that's a very important part, that, if you share things, then people can figure out what works. So Bhunshai, on that note, let me come to you. I know that there are some slides also you may want to share. We're looking at either side, the computational or the institutional. What are your thoughts on this difficulty?
Let me starting with this. Thank you. At first, thank you for this opportunity to discuss. It seemed to me at first I very confusing about what we are going to talk about, but at the end I know that it common challenge and problems in in the health and digital and the IT side. I'm come from the more on the health policy and management and also the informatics side. So let me kind of do you see my slide?
Yes,
Starting
we can see
that we are talking two things, digital health, that our keynote are talking about the governance of both the digital health governance and digital health data governance, and also the digital transformation as the big pictures allow that. To me, I think that we talk a lot about AI, and the AI has been now coming to kind of the we cannot avoid that, and it's because it emerged, it revolutionized because of three things. I'm work more on the data, so I will not talking about the new algorithm and the large language model or the GPU, the computing side, but more on the data side. To me, I think what we mean by the equitable to collect or procure share data, it means that we can use health data, like Anurag say that it's both sides. If we careless, then it's dangerous. If we don't keep it so secure, then how we gonna advance on the advancement in health, like diagnosis or treatment. So the issue of collect, share, and govern, all these things is very difficult in terms of the institutional line or technical side line. So to me, I think the data collection of procurement has three big challenge. I will talk more about the general challenge. You can see that data is fragmented. It's not. It cannot integrate and interoperable. So, and it's also locking in many places. The second that we just our panel just discussed about the quality of the bias and the standard of that. And the third part that Anurag said about the trust, the privacy, something like that. This also very common. Switzerland is a very big, a very good example that even to create a national digital ID is kind of the very difficult compared to us, like the developing country. Thailand has the citizen ID. India has the Aadhaar. That is, it seems like simple, but this is also the trust and consent of this to the government. For Thailand, I will give the example for Thailand. How we can get this kind of the equitable, both correct quality of data and also fair use to all parties, not just the hospital, clinic, something like that. And I come to the basic, like we found that most when we have a very high technology, we already forgot about the foundation and the governance things, the architecture, the data, and interoperability and human are all the basic that we gonna do the digital transformation. And for Thailand I mean, we are also struggling with all of these. First, we still have fragment data. We're trying to do a lot on the interoperability. I will come back about the interoperability a little bit. The second thing is the quality of data and the standard. Right now, in the past 20 years, we developed several semantic, syntactic standard and technical standard, but it's still not enough. But we also achieved something like we have national drug ID, Before we cannot do the integration, now we can do the more integration of data and also use that data to do analysis, to do the utilization across the countries. For the trust and consent, even we have two big law like the PDPA, like the GDPR, and also the cyber security is still we still fighting on this.
I think it's important to know, Bunchai, that all of us are struggling through the same things, and it's really good to see that you are making progress along the same lines of thought that we've been outlining today.
Yeah, I just to give you the standard qualities, to have the standard like this one for the e-procurement. One, before we cannot integrate. Once we can integrate the data because of the standard, semantic standard of the duck code, like the national ID, now you can see we can analyze the utilization, identify which country, which clinic has been used, something like that, and come up to the interoperability. There is so many layers, right? But I think the question is here, is the people, is not the technical, both governance and also the thing. And what my experience is that we also project those to the data and the technical, but people are not talking. Governance, I study about the governance model for the digital health in Thailand. So same every country, India, Australia, US, the same thing. How we gonna do the guardrail of the AI? To me, I think we have to do both for the data. I will finish this. I'm not quite sure that.
Thank you, Bunchai. I think your wonderful message that I'll remember. We disguise interoperability problems, and the problem is really between humans and institutions, and we call it data and technical. That's so true. I think this is a perfect time for us to move on to our spotlight speaker for this webinar, and thank you so much, Bunchai. Jayanta, you have seen Sri Lanka's system grow from up close. We would love to hear from you regarding how you see things going and how do you think Sri Lanka is looking at this problem. Over to you.
Thank you. Thank you, Dr. Anurag. Can I share my slides?
Yes, sure. You should be co-host by now.
Thank you. Is that okay?
Yes, perfect. Please go on.
Thank you. Thank you and very good afternoon. And it's indeed a pleasure to be part of this session this afternoon and hearing the perspectives from different lenses, so to say, to go immediately into my subject and the pith and substance of what I'm going to say is that from a governance perspective, to support and facilitate AI in health and to perhaps provide the regulatory structure, one of the areas Sri Lanka has been involved in fast tracking is the Personal Data Protection Act, which was adopted by Parliament in 2022, number 9 of 2022. And as we speak, last week, there were certain crucial amendments which were approved that will also help to define the date this law will come into operation. So whilst it's a regulatory tool, important point to highlight is that it is a facilitator, enabler for the digital economy, and the intended regulator sought to be established under this new law, which is called the Data Protection Authority. Is supposed to create a interoperable legislative rule-based framework that will strengthen cross-border cooperation between all of our countries. And I think India, Sri Lanka, and some of the APAC countries can collaborate effectively once this brand new regulator is fully in operation. It is the board, the chairman and the board are appointed. The Director General and staff are yet to be put in place, but the overarching factor that I want to highlight is that this is a law that many of you are familiar with. It regulates the processing of personal data whilst giving certain rights to data subjects in relation to processing of personal data. More notably on the point we are discussing today, what I thought I'll highlight are some of the key terminologies which are relevant. While personal data is defined, we have these yellow colored parts which I have highlighted from the definition of special categories of personal data. Standard boilerplate kind of language you see in principle-based laws stemming from the OECD privacy framework, APAC privacy framework, as well as GDPR, that influence the formulation of our law. So in terms of who and what kind of entities are regulated, the standard controller processor language is what we find in our law, which covers the full suite of cross-spread entities from healthcare providers, both in government and private sector, which will be regulated. So why I thought I'll highlighted the special categories of personal data that will cover the processing of genetic data and data concerning health is because of the underlying principles that is provided for in the regulatory stack, including principles governing data processing, covering lawfulness, purpose specification, data minimization, confidentiality, integrity. And then comes the transparency as well as the accountability obligations built in part 1 under the principles of data processing, where every controller is obligated to have a data protection management program. So the impact this would have on health providers, including those involved in AI systems or embarking on the use of AI systems, will necessarily be obligated to comply with those governance requirements, followed by certain rights that accrue to data subjects. And then in relation to cross-border data flows and controller processor engagements, for example, when AI systems are included in day-to-day operations of any healthcare provider systems, how those contractual frameworks should be regulated is also covered in part 3. And then we have adjusted the cross-border frameworks to provide ease of access to cloud-based services that you will see in a moment when I highlight the amendments. Now, in terms of lawful basis for processing personal data, on the left-hand side, you have the personal data basis for lawful processing, but on the right-hand side, the number of options provided for processing of special categories of personal data lawfully includes areas such as for treatment, prevention of communicable diseases, and management of health care. So consent is not the only basis for lawful processing of special categories of personal data, but we have provided for a number of options. But alongside that comes the rights available to data subjects, where in the context of AI, we need to be mindful that there is an option provided for review of automated decision making, and there were gaps in how those review options provided, for example, in section 18 of our PDPA can be actually invoked through to a controller and through an appeals process to the Data Protection Authority. And there are a couple of gaps in that, which has now been cured through the PDPA amendment of 2025. And then clarity has been provided with regard to how a data subject's request should be responded to by a controller and the timeframes for responding to each of the requests. And most importantly, the 2025 amendment narrows down the scope of a public authority so that a public corporation, government-owned business undertaking would have the same status as a private sector institution, provided there are necessary safeguards that are contractually put in place. There is freedom provided for adopting cloud-based frameworks, but with the right provided to the regulator to work with the respective authorities to restrict data flows for certain categories for which restrictions may be imposed in future through a consultative process. On the Data Protection Authority's mandate, quite a sweeping mandate, I would say, that would include safeguarding the privacy of data subjects from any adverse impact arising from digitization, which would also include adoption of AI. And in terms of remedies and actionable measures that the regulator can take, in addition to the power to issue directions to a violating party to get themselves back on track, there's a penalty provision with certain maximum penalties. And of course, in Sri Lanka, we are mindful of the problems in Europe emanating from a percentage of global revenue. We have not gone that route, but we have provided for a softer framework with certain measures where those impacted can even appeal to the Court of Appeal. So it's an entire administrative law stack that has been put in place. But more importantly, in conclusion, I just want to highlight something that is of significance and relevance for today's session, Dr. Anurag. So here, I think I just thought in my last slide, I would highlight something, the new kid on the block that came out in September, white paper on AI in medicine published by the Ceylon College of Physicians. This is very much internal, being distributed amongst the various colleges within the College of Physicians in Sri Lanka, where amongst the recommendations in the white paper on AI in medicine, in terms of governance and regulation, there's a recommendation to establish a sectoral advisory committee under Section 32 of the PDPA, so that the newly established regulator will be guided in the formulation of rules, regulations, and guidelines for use of AI in medicine. And then also an additional recommendation to provide for a regulatory scheme within the existing frameworks to evaluate and approve and monitor AI tools in medicine to ensure safe and ethical use of AI within our country. So with that, I think I will conclude. I just summarize what I have to say in the interest of time. Thank you.
Thank you very much. This was a wonderful insight into how the problem is being dealt with at the Sri Lanka level. I have just one question for you while we see if anybody in the audience also wants to ask a question. I think today was a particularly clear and agreeable discussion where I think almost everybody would agree on the importance of what was said. But do you find that people after this act are saying this is blocking the development of AI, slowing things down, because India has also passed a Digital Personal Data Privacy Act, and suddenly the flow of data stops temporarily while people figure it out. So what has been your experience in Sri Lanka after passing this act? Have people been happy? Has the private sector complained? What has it been like?
So a mix of both. While there are those who have some concerns whether the PDPA might be a potential barrier for innovation and growth and AI adoption, because the definition of processing covers a range of activities in relation to processing of personal data, including carrying out of logical arithmetical operations on personal data. So which would necessarily mean the use of AI with personal data would be coming within the regulatory stack of the PDPA. So concerns were raised around it. But what I see from a larger majority of others who use or who have found this law to be a facilitator, the argument is in the direction that this law in its very preamble talks of this being a facilitator and an enabler for growth and innovation in the digital economy, and also to provide an interoperable framework with other global standards. So depending on how the other global standards evolve, how this will help shape the regulatory frontiers within our legal framework is to be seen in future. But I would conclude in my submission by saying that the way I see it happening is that it would more be an enabler, because we have set up a principle-based framework with a soft law kind of a remedy, namely a directive, which is followed through by a penalty in the event of a further violation. So it's a two-step approach. That way, one can argue that it is more of an enabler and provides and facilitates greater use of AI, including in medicine, with appropriate guidelines being introduced in future. Thank you.
So a very important question has been posted. Given that in the private sector, where there is often health data, you can be penalized for sharing it wrongly. But incentivization may be required to get you to share it all, because if there is only risk from the point of view of the doctor side that contains the data and no reward. So the question is, how difficult is it to procure data from the private sector without incentivization after data protection acts have come? Because earlier, you reached out to doctors, they were willing to share data quite often. Do you see that without incentivization, people are now going to refuse to start sharing data? Has that been your experience? And first, Janta, to you, and then Bunchai, perhaps you can give the Thailand experience, and then we'll discuss India.
So, Dr. Anurag, I would say that we need to see how the regulatory framework evolves. I may not be able to predict how the data protection regulator behaves, but let me say this. In the broader scale of things, if sectoral guidelines as recommended by the Ceylon College of Physicians is formulated, and those guidelines are very specific in terms of how that sharing can take place with appropriate guardrails, I think we can have a win-win situation. That is how I would look at it, because fundamentally, the Schedule 2 that regulates the lawfulness of processing of special categories of personal data, i.e. health data, covers a spectrum of options beyond consent. So if for the treatment, and if it's in the best interest of the patient, there's a requirement to further share such data sets in a treatment life cycle, that is also possible. So I would say that maybe the guidelines might take care of it, with a caveat that the current stack as it is provides for options, and we will know how this works when the law comes into operation post second quarter 2026. Thank you.
Thank you. Bunchai, any experience from Thailand that do you need to incentivize the private sector to share data?
In Thailand, 80% of the hospitals and maybe 70% of healthcare are serviced by the public government, and we have the universal health coverage. And the sharing data are incentivized by the financing system. I think this is a very difficult question about doctors don't want to share. They expect private. They think they will lose the patient, something like that. But don't forget that that doctors are trained to do the Hippocratic oath that we we have to do no harm and the best for the patients. I think this is the same for 200, 300, or 700 years, that we will still have to create moral among the doctors and still doing this as the community of the physicians.
No,
The
thank you. So
incentive is
interestingly,
financing for
yeah.
sure.
So Thailand is 70 to 80% of healthcare is public. India is the other way around. So Sangamitra, Gautam, either both of you, your thoughts. Will we need to create incentive structures in India to get data, given that about 2/3 of our healthcare is with the private sector? Or do you think we'll figure out other ways of doing it?
In general, I'm not too much in favor of incentives because I mean, the sort of model imperative should be there. And if you look upon it only as a financial or related incentive, then that dilutes, in a sense, the purpose of this. But I think one indirect incentivization would be continuity of care across multiple providers. So it makes it easier for the doctor if to take a new patient who comes, if they have access to what treatments they've had in the past. And I guess with some question of the Hippocratic Oath, if you want to do the best by your patient,
Is the best.
then that information
Make their
is
life better.
important.
Make the doctor's life better because they shared the data.
That's right.
That
That's
might
right.
be the best. Sangamitra, your thoughts?
Quickly, Anurag, I think sharing of data has been a challenge with or without any Privacy Act, right? It has always been a challenge in India, particularly. We faced it. I mean, nobody wants to share data, let alone private sector. Even the organizations, government-funded organizations, they are allergic to sharing data because I think everybody feels that, okay, I might make one more research publication out of this. So there is a hesitancy, in a big way. So I think in the beginning, incentivization, I agree with Gautam. I think incentivization, well, later on maybe, but at this, I mean, there has to be getting the best out of the data should be incentive enough. And also in the beginning, to get into that culture of data sharing, I think regulations have to enforce, particularly government public funded, all studies, the data has to be made public. That has to be enforced. It's not left to the choice of the individuals. And for the private sector, some form has to be worked out because indeed they are spending a lot of money in collecting that data. So sharing through some regulations and data sharing has to be enforced, adequately protecting the privacy. But I think regulations will need to be in place that you have to share data.
So I think in the end, we will end up with data solidarity. That's where we open with a keynote by Professor Kickbush. And ultimately, society, doctors, everybody has going to have to come together because there is shared value for all concerned. Where risk is low and value is high, make it compulsory. Where risk is high and value is low, just ban it. And I think regulatory governance is the way, and that will partly answer Divakar's question that I can see on the chat, because the law is not clear yet, but as long as you identify benefit of use, it gets better. I wish I had a small cartoon that I saw recently to show, but I don't. But it's about a Cobra Act in India a long time ago, when at that time the British who were ruling India decided to give money to people because they had too many snakes. So everybody who brought in a dead cobra would get money. Very soon, growing cobras became an industry because it was easier to grow them than kill them, than show them to the British and collect some money. So any form of incentives can be misused. It's almost impossible to create financial incentive structures that are not amenable to misuse. I truly believe that a proper solidarity framework, balancing benefit to all sides, is the only way forward, and it starts with great governance. Thank you to all the panelists. Ilona is, of course, not here. Jayanta, for a wonderful description about what's happening and your thinking process in Sri Lanka on data privacy. Bunchai, for your thoughts on Thailand. And of course, to my co-panelists from India, providing great insights into the ecosystem. We are slightly over time, about 10 minutes, but I think with a tech glitch that is hopefully not too bad. And these things will happen. And one must remember, tech will periodically fail. And all governance and all regulation is about making sure we don't hurt people when that happens. Thank you, everyone. Bye.